This is a tremendously exciting topic. I think it's just really paradigm shifting. I think the more we see with weight loss and with semaglutide or and the other GLP-1 agonists, we really see just an incredible opportunity for patients and to really transform healthcare in the U.S. I think the reason wanted to touch on this in the aesthetic space is there's a lot of movement right towards biorejuvenation, towards kind of self-healing, so to speak. That we've seen a lot of the backlash against things that people view as foreign materials or whatnot in aesthetics. And I think there's a lot of debate around semaglutide that some providers I think are very anxious about, do not want to get involved with it, which is understandable. And I think that's, as long as we've thought about what's best for our patients, I don't think there's a wrong answer. But um, it's a really big opportunity, I think, and it's a way we can really add a lot of value for our patients. So let's go to the next slide and kind of jump into it. All right. So why delve into weight loss now? We have a lot of stuff we do at Portrait is really driven by providers, and we have had providers who have asked about, bringing on semaglutide for over a year, certainly at this point, probably a year and a half. And it's something that we've looked at carefully. And one of the things is, right, any new drug has its unknown issues, and sometimes it takes a while for those to become identified. And certainly there are some rare one-off type situations that have occurred, and we're aware of those, and I'll talk about that a little bit later. But this is a really substantial, widespread issue that obesity and overweight are incredibly common and health impacting problems. Body size and shape are frequent concerns of aesthetic patients. As a lot of us know, I always feel like as some dermatologist by training, and although I might not be able to get people to wear sunscreen, to prevent skin cancers, I can usually do it if you sell it as an anti-aging adjunct. So I think that's kind of, hey, we should use every opportunity we have to make a positive impact for our patients. The safety of established GLP-1 agonists such as semaglutide is really pretty robust at this point. There's a lot more drugs in this space that are going to be coming to market in the next couple of years, and even to a degree next year. Probably a lot of folks on the call are also familiar with tirzepatide or liraglutide. I'm not really going to get into those too much, but a lot of the same thought process applies there. It's just still some issues with sourcing and things like that. But across the board, basically GLP-1 agonists far and away quite safe, particularly when you compare it to the known impacts of obesity or being overweight over the long term. The regulatory environment. So that's something we've really looked at carefully. In some instances, and you may have seen also, there have been lawsuits filed by Eli Lilly and Novo Nordisk against compounders and med spas, both for the way they've marketed online and also in person. And most of that has really been related to people using brand names and saying, hey, I'm selling Ozempic here, and then they're not selling Ozempic, or where they've really been doing things that are grossly inappropriate. There have been some signs where the shortage of these drugs was going to relent, and it comes off of shortage list for maybe a week, and then it comes back on, and so that's been going on now for several months. And as far as I can tell, there's a high likelihood that this intermittent shortage it will persist. Even if it doesn't persist and semaglutide becomes something that is no longer something that can be compounded, there are other ways to actually keep people on these GLP-1 agonists, even if that were to happen. And I think that's really important that we don't start something that we can't continue. I never want to do that to patients, right? If we do a treatment, we should be able to manage the complications. And here, I also wouldn't want to start offering something and then 3 months in say, oh yeah, we can't treat you anymore. I think that's a bad look for patients. we're a lot of providers based in California, probably a lot of people on this call, and so reliable and safe sourcing of GLP-1 agonists now can be done into California. This has been an issue with bringing, basically from the pharmacy board, California Pharmacy Board, bringing compounded semaglutide into the state has been very difficult. And then market forces maybe narrowing the window of opportunity a little bit. So I think it's kind of like now is the time to do it. And the reason is seeing more and more direct to consumer health ads around this on TV, on the internet, all over the place. And so I think if you don't capture these patients now, there's a decent chance that someone else, or a high likelihood, I would say, that someone else will within the next year or so. So I think it's the time to do it. Okay, let's go to the next slide. So just going through things we already know here, but obesity, I think there's a lot of talk around health, wellness, taking care of ourselves. I feel like it's talked about all the time, but maybe it's being biased in the aesthetic space that a lot of folks here think about that more. Certainly obesity is just, incredibly prevalent in the US, and even over the last 10 years, well, over the 2011s, or 2010s, it became really, widespread. So the patient base is there. All right, let's go to the next slide. So basically, one thing that comes up a lot is, why do we need to do this? And I think a lot of providers might take the angle that, hey, this is not something that it's, weight is weight, the whole like calories in, calories out type argument that's been out there. But really, obesity is a disruption of energy regulation and this vigorous defense of the higher body weight set point that you've got, different external influences with emotions that go into food, but hunger, satiety, hormones, genetics. There's a lot of heterogeneity to explain why someone develops obesity, and that can make it really difficult, I think, to figure out what is an appropriate treatment plan. Because for some people, it's it really is a lot far and away genetics. For some people, it's stage of life, hormones. For some people, it is that stressful job and they're snacking. I mean, you get all kinds of different reasons, but it does make. I think it's part of the reason treating it can be so difficult. All right, next slide. So I kind of alluded to this earlier. Sorry, it's a little bit busy text on the slide, but basically, there really is a dramatic underutilization of treatment out there. I think it makes sense because really a lot of the medications that were used are have not been that effective. So one is just telling people, here are all these different ways to lose weight, and obviously that that's been done. There's a million different programs out there for weight loss, but really high frequency, vigorous exercise typically results in about a 5 pound weight loss over 8 to 12 months. Going keto might get you about a 10 pound weight loss over 2 years. And then if you're doing both of those things, for somebody who's obese, they might be able to get about a 10% weight loss over 1 to 2 years. So I mean, that is a lot of work, transforming their life. And, if someone is, 300 pounds, they lose 30 pounds, that's great. That's, impactful, but it's probably not where they want to be. So, it's not something people like to talk about, right? And it's something that oftentimes patients are uncomfortable talking about. Providers are even more uncomfortable talking about it. This is interesting to me. In 2019, only about 2.5% of patients with obesity were on an anti-obesity medication. In 2023, about 1.7% of people had been prescribed a semaglutide, medication or GLP-1 agonist, which is a 40-fold increase over the past 5 years. And that was done by Epic Research. I just think that's fascinating, right? So you can see the adoption has been is really like on that hockey stick trajectory right now. And I think again, kind of coming back to why I think this is really a great time to get to get experience with these drugs. Patients with obesity often fear judgment and bias. Again, coming back to this, just work out, eat less. Calories in equals calories out. I think providers don't know that much about this. I frankly don't think too much about weight management. Again, being a dermatologist up until the past, year and a half, really, where started to see these drugs that are safe and effective. Historically, diet drugs have had a lot of problems, heart attacks, strokes, all these different issues with them. So it's no surprise that people have been hesitant to explore it. And then weight loss surgeries is, another option, but loaded with all sorts of long-term, headaches from that without getting into those. All right, let's go to the next slide. So adipose tissue, it's an endocrine organ, right? And you're trying to change an organ. And so it really is, I just want to keep harping on this, on the complexity that's involved, that it is a major organ, probably in some ways, the largest endocrine organ in the body. It secretes these adipokines or bioactive peptides. They act throughout the body. They impact the activity of the GI tract, like the liver and pancreas there, but also the vasculature, the muscle, the brain, and really provides communication with distant organs, including the central nervous system. So um, it's not something that's just a storage, just weight. It has a lot of activity in the body. And let's talk about how semaglutide works if we go to the next slide. So I think a good way to think about it is there are a lot of factors that go into someone feeling hungry or full. So meal quality, if you think you're going to a great restaurant, you're probably going to feel more hungry. If you think you're, going to the hospital cafeteria, maybe you're not so hungry unless you're stressed, in which case you're just as hungry. Um, then the meal quantity, where things like, fiber or whatnot can increase stretch. So someone might feel more full. Osmotic load, if you're having, sugar alcohols, things like that pull fluid in, that can make someone feel more full. CCK, PYY, ghrelin, these different uh, adipokines, and then GLP-1, where produced in abundance and really has a direct effect on the brain. Other signs, for satiety, nutrient status with insulin, oxidation, glucose, amino acids, and then your energy balance of insulin, leptin, and that is something where it really comes into, again, that whole set point theory that's I think become more and more established. But basically, this is a pretty early step where someone is eating, but pretty quickly going to start to feel some effect of satiety, through GLP-1. All right, let's go to the next slide. And so just the long-term complications, that why this is so important beyond somebody's body shape, right? That type 2 diabetes, heart disease, cancer, osteoarthritis, heartburn, sleep apnea, non-alcoholic fatty liver disease, and stroke, just some of the major associations. And the cancer one really carries across, many different cancers, actually. So that is, I think, not something to be overlooked. The next slide, the cost of obesity, that about $1,800 per year per person with obesity in terms of healthcare incurred costs. And so that's a lot, but I think what's interesting is it's probably not enough to move, which is maybe sad. It is sad. Probably not enough to dramatically move the needle from an insurance standpoint. Like, I think there's going to be a lot of pushback from insurers on covering, Wegovy, Mounjaro, Ozempic, all these drugs, if it's not in the setting of diabetes, because they are expensive. It's hard to find out what what insurance is actually paying on them, but typically you're looking at list prices over $1,000. So, whatever, maybe they're paying $8,000 a year. For some insurers, from a business standpoint, they might not be that interested in covering it, honestly. And that's just, US healthcare as it is. So, the life expectancy, also 1,300 deaths in the US per day attributed to obesity or overweight. So we think about how, damaging the COVID pandemic has been. And it's like, well, obesity is right there every day, has been for quite some time. So tremendous impact on Americans. think here I can skip the left side, but basically, talked about the negative stuff about obesity, but really, what are we trying to do with this? Trying to also increase self-confidence. We're trying to increase the likelihood of job promotions and higher wages and increase energy level. All the kind of same, um, effects really of a lot of the aesthetic treatments we do that, we want someone to, look better, but it's really just as much how they feel and how that impacts their daily life. Um, all right, let's go to the next slide. So, clinical use guidelines. So, yeah, we can pop right in here. So basically, who can use semaglutide? So the FDA indicates semaglutide for lowering blood sugar in adults with type 2 diabetes, in addition to diet and exercise. It's also for chronic weight management in patients with a body mass index of 27 or greater who have at least one weight-related condition. So type 2 diabetes, high blood pressure, high cholesterol, or also just alone in patients with obesity, basically BMI greater than 30 or 30 or greater, I should say. And this is the first FDA-approved drug for chronic weight management in adults with general obesity or overweight since 2014, which I think may have been Orlistat. I actually don't recall off the top of my head, but basically the first one of any impact really ever. All right, next slide. So who can use it? Basically, I think it's reasonable to use it on really anyone who is overweight with a BMI, between 25, even over 40. But if their BMI is over 40, they certainly should be getting additional help, probably, potentially surgery or whatnot. But seeing somebody who really focuses on weight. The Actually, let's go to the next slide even, because basically, you know, this is a busy chart. I think we've all seen this at some point, but just wanted to reiterate that you still want to adjust for muscle mass and race, and that someone who, different ethnicities, right, have different mean BMIs, and in some patients, it really probably doesn't make sense to be using semaglutide in someone who's muscular with a BMI of 26 or 27, but in somebody who is, really has a natural, a very slight build to them, but is carrying a fair amount of particularly visceral adipose tissue, it could be worth pursuing it in somebody really who has a BMI just 25 or 26. Okay, next slide. So who can't use it? So not many people really. Um, we don't really recommend that providers try using this in type 1 or type 2 diabetics using insulin, and really even ones who are not on insulin. That is done occasionally for type 2 diabetes, even when somebody's on insulin, but you have to be really careful about risks of hypoglycemia. And really, even if somebody is on, if somebody has type 2 diabetes, at least this is just my opinion, but you're here, so you got to hear it. That if they have type 2 diabetes in any sense, it's probably better if that is managed by their primary care physician or an endocrinologist, somebody who's really going to be watching that carefully. Anyone with a history of multiple endocrine neoplasia syndrome type 2, probably not going to run into them, but it's possible. And then a history of thyroid cancer, or a history of pancreatitis. In pregnancy, so this is one that's probably the most relevant, but if a patient is intending to become pregnant at some point, I would probably just not even start them unless they're thinking like, next year or something. But the prescription should be discontinued 2 months before attempting pregnancy. Dosage adjustments might be necessary for patients with renal impairment. And so this is just a note for people actively affiliated with Portrait that you would want to contact your clinical director to talk about, what needs to be done. Like if someone has active kidney disease, it's probably a reason to, at least monitor them carefully, get labs, but more likely even just refer them to their primary care if they're willing to prescribe it. You may also know, I know patients where I've tried to send them to primary care, encouraging them to get on semaglutide, and the primary care docs, for one reason or another, have been hesitant to do it. I think sometimes just, again, the insurance side, unfortunately. Okay, next slide. So for nurses, for registered nurses, the way, again, we think about at least good faith exams for semaglutide or GLP-1 treatment at Portrait is that we need a baseline weight, obviously, and a body mass index. Ideally, you'd get the weight in the office. There are obviously, again, many companies trying to do this completely remote. So I think it's reasonable to just have the patient tell you their weight, but just reality check it. Um, Body dysmorphia, it's out there, as you know. I definitely want to confirm that there's no active gastrointestinal issues, insulin-dependent diabetes, or MEN2, that the patient is not pregnant or seeking pregnancy, and then to confirm no history of thyroid cancer or pancreatitis. Again, if the patient is on a blood glucose lowering medication, probably should be managed by their primary care provider. And then the way it works right now is we would just ask you to send a message to the clearance team, and would make a quick note in and say, yes, this patient is a candidate and we can administer. Um, this is just how it's done at Portrait, but if for folks who are on Flex or even not affiliated with Portrait, I think these are just good steps for anybody to do. Pretty standard. It's pretty straightforward too. And then in the future, we're going to be gathering this information directly in the patient registration flow and basically asking patients, hey, are you interested in exploring weight management? And if they are, we'll gather this information up front so that, there's an easier workflow for patients who do want to start it. All right. So procure, storing, and dispensing the medication. So Portrait will dispense this medication to your office. Sometimes this is going to come from headquarters and sometimes from pharmacies directly. It just depends on the state because there are a lot of um, differences really in how it can be done in certain states. Um, Initially, the way we rolled it out is that patients would come in for their first injection and then to pick up vials going forward. In the future, in most states, it could be sent directly to patients from a pharmacy. I think there's pros and cons of that because there is some upside, right, in having the patient back in your chair. One is, I think, really related to the semaglutide, you're probably going to get better outcomes because it forces a bit of accountability, a bit of a discussion. You really still do want to be doing this in conjunction with, eating well and exercise and really kind of trying to make sure the patient has continued those good habits. It's also, from a business standpoint, right, a great opportunity to continue to connect with your patient and offer them other aesthetic services that you provide. So, my feeling is, in general, it makes sense to have patients come in to receive these, and I think that is what's typically done from the conversations I've had with other businesses and with compounding pharmacies as well. It should be refrigerated but not frozen, and then administered via subcutaneous injection once weekly in the classic subcu spots, abdomen, thigh, upper arm. And then same thing for a patient, if they are going to administer at home, just to keep it refrigerated, rotate your sites, obviously clean the sites prior. Some people report fair amount of discomfort with the injections, but typically it's nothing, outrageous. And I should also add that semaglutide, it can be given orally. I think it's Pfizer who's doing trials to try to, get the labeled indication for it, for them to be able to market it. But you can also get semaglutide tablets compounded orally. Currently, it is more expensive though, and so I think for most people, it's probably not worth it. Also, the early signs I would say are that the weight loss is not as robust. So if you're going to be doing this, and you're getting maybe more like 5 to 10% body weight loss versus more like 15% with the injectable, I think most people would be willing to deal with the injection. Okay, next slide. Okay, so titrating. So it's a ramping dose, and this can be a little bit confusing, I think, because basically folks typically are going to get different size. When someone's on, I should back that up. When somebody's getting Ozempic, right, they're getting a pen, and that is nice because it's straightforward. Here, when you're doing compounded semaglutide, typically it's going to be coming in a vial. And so it's important that the patient understands what their dose should be and what the dose escalation pattern should be. It doesn't have to follow this directly, I would say, but generally, first month is 0.25, next month is 0.5, next month is 1, and then people can kind of go up usually to either 1.5. If they're not having any side effects, you may even consider jumping quickly, like just 1.5 for a week or two, and then right up to 2. And then week 17, when it's compounded, usually it's done as 2.5 milligrams. For Ozempic, it's usually 2.4 milligrams. And just want to reiterate that this really, like anything, right, in medicine, this can be personalized, that there are a lot of patients. I think I mean, I started using this sort of begrudgingly. I didn't really, again, as a dermatologist, want it to get into weight loss, but there are certain medical conditions where I think it matters a lot. And then for some aesthetic patients also, where I thought it really would add a lot of value. And a lot of people only need 1 or 1.5 milligram dose, and they're happy. Some really do want more, or two, like 2.5. And then some people do skip doses when they don't think they're going to follow the treatment guidelines. So I'm sure not a lot of people, did their semaglutide injections like the last week in December because they probably knew they would feel terrible. And they really can be pretty uncomfortable if they aren't following the guidelines on how to, what to do when you're on this drug. I'll talk about that a little bit more here in a moment. The other thing is that really it's something where folks do, I think one thing is that they do have side effects. Nausea can be significant, constipation can be significant. Those are, real frustrations. So I don't think you should feel like you have to get them to the 2.5 milligram dose, that they're somehow not being managed optimally if they don't want to get there. Because as long as they're kind of moving on the right track with their weight, I think that's probably fine. And it's better that they're able to stay on the drug and be happy and feel well, and and associate this with a good experience for you and for your business, than to be miserable to lose a few extra pounds. Okay, let's go to the next slide. And so for expectation setting, basically, usually blood sugar starts really immediately after starting treatment, but the full effect may take several weeks. Semaglutide is intended for ongoing use, and so typically when somebody stops the drug, the medication effects are lost. And most of these study outcomes were measured at week 68 after the starting dose. The challenge too is, when someone has lost weight, again, coming back to that set point theory that has become, almost a set point law, that even after they lose weight, if you look a year out and you were to stop the drug 2 years out, you'll still see these persistent hormonal shifts where, their leptin and ghrelin signaling is telling their body, hey, you're starving. So it's going to be really difficult, I think, for patients to stay off of this long term without starting to gain, weight back gradually. Um, Not saying that everyone is going to be on it, but I think most people will end up staying on it long term. All right, next slide. So in terms of expectations, so this is one of the landmark studies published in the New England Journal that, again, over 1,900 participants, 15% of weight lost in semaglutide versus 2% with placebo. And again, from baseline, 33 pounds were lost in the semaglutide group versus 1 pound in the placebo group. So, and there's always variance in studies, but basically, authors felt confident that at the minimum, the estimated treatment difference was 27 pounds. I mean, 33 pounds versus 1 pound is, really dramatic. I mean, just transformative. Participants who received semaglutide had greater improvement with respect to their cardiometabolic risk factors and a greater increase in participant-reported physical functioning from baseline than those who received placebo, meaning like joints weren't hurting as much, breathing was better, able higher energy level, those kind of things. Okay, next slide. So again, more on expectations. Basically, this is a separate study, NIH. At 3 months, folks had lost 6% of their total weight. 6 months, it was 11%. And you can just get a sense of where somebody, the range of what people might expect. So it is variable. A lot of this is going to be baseline weight. Do they really only need to lose a few pounds? Or are they walking with a BMI of 40 or 50? Their genetics, and then really how they do incorporate other health measures that diet, exercise are still obviously relevant. All right, next slide. And so how does your patient get the most out of this medication? Again, it's going to provide less results without changes to lifestyle. Water is always a good idea, right? That really does help with satiety. Again, feeling that there's and that's something that I think a lot of folks are aware of, but it really can be quite confusing to a lot of patients. But if they are dehydrated, a lot of times people mistake that for hunger. It's a really similar signaling pathway in the brain, and why it happens that way, I don't know, but it is, if they're dehydrated, they probably are going to be eating more, and if they're really well hydrated, they're going to be feeling better. Limit alcohol and beverages and foods with high sugar content. Eating a balanced diet rich in whole foods, fruit, vegetables, lean proteins, and whole grains. This is just a dietary resource that we can make available. I think it's quite helpful. And then usual, exercise regularly a few times a week. Okay. And so, for selling this service, like everything, right? Expectation setting is huge. And so I think it's reasonable to tell them expect about, you could say 5% if that's easier, 5 to 6% in month 3, 10% or 10 to 11 at month 6, and about 15% at 1 year. That's going to be for somebody, again, who needs to lose that amount of weight. If they're coming with the BMI of, 27, hopefully they're not losing, or 26, not losing 15% of their body mass. But I think it's just something where you would, they should be happy. They're probably going to get the result they want. Still stress patients that they need at least 4 months to really expect the changes. And the reason, again, early on, right, they're on a very low dose. So it doesn't mean that the medication's not working. This is one of those things where there's so much positive press that I think if a patient isn't seeing dramatic changes early on, they do run the risk of saying like, this drug is not the real thing, or, this provider doesn't know what they're doing, or this is all a scam, or whatever, people come up with all kinds of thoughts. So expectation setting, but I'm sure everyone on this call knows that. Lifestyle changes are maintained with this ongoing cultivation and motivation. I think it's great to have a chart and really to update it at each visit to check in with patients. It is a journey. Remind them that they're going to have better outcomes if they couple with diet and lifestyle alterations. And really, large meals or alcohol when somebody's on this can really, I just want to reiterate, that can make somebody really uncomfortable. It's the same thing if somebody, I'm going to anticipate right now, the question will come up like, what if somebody overdoses on this because patients drawing it up themselves? They basically feel crappy. They are nauseated and they're super constipated, and it might last a week, 2 weeks even, but not dangerous. But basically, they are going to feel uncomfortable to the point that some people then will say, oh, I need to start them on like Zofran, or I need to start them on, some other drug to help with the, constipation beyond fiber. And I think that is unfortunate. That's like the traditional peril of modern medicine, right? Where we start somebody on a drug and then just starting on more drugs to treat the side effects of a drug. And I would just encourage you not to go down that path, even if it seems like the easier one sometimes. Recommend packaging this as part of an aesthetic service you provide, all as part of your patient's glow up, because it really is, a big part of how they're going to feel about themselves. Not just, right, it's like aesthetics. It's not just the face, it's the neck and the hands, and it's also the body. And then I would say, it's good to have a careful conversation about fillers and biostimulants prior to starting, because there is going to be some laxity and some facial volume loss in some patients. And um, I don't think that's bad. I don't think it's bad to do fillers or biostimulants prior to them starting it, but you just don't want to set yourself up for an unhappy patient where they're saying, "Well, I was really bothered by my, tear troughs," and you've made them worse. And it's really, well, the drug is working. It's supposed to happen that way, but just something to be really, thoughtful about when starting this. Okay, next slide. So pricing, prices have dropped not very long ago. I would seen it more like in the $700 range. And I'd say now if you go on to like various direct-to-consumer sites, you can see it as low as 300. Occasionally you'll see something even less, but usually it's actually not including a consult fee, or it's not including the drug. It's or it's including just a starting dose or something like that. So I don't want to mislead there, but you may see numbers that are less. And then on the upper range, 550, I've seen as high as 650, but usually it's more in that, I'd say like 450, 450 is kind of a standard price. And like in aesthetics, there are bargain basement places that don't do things the right way. So where they don't do stability testing, where they have non-medical grade ingredients, et cetera. And so that's something I would say definitely to talk with your patient about, that they could ask the place who's received it or who's offering them this deal, like, do you have a certificate of analysis? Do you have stability testing? Do you have sterility testing? Is this a research salt? And ask for that kind of documentation. I don't think many people would do it, but at least you can show that you are thoughtful in your process about what you're providing to your patient. The same way, I'm sure many people have had that conversation about, like, well, I was able to get, my Botox for $5 a unit. And you're like, okay, well, that's not going to happen. Um, Set the expectation that this is a journey. This is a great opportunity to have somebody on a membership plan, because as I said before, most people are going to need to be on this long term. Okay, next slide. So monitoring. Um, you want to get a baseline weight and body mass index and repeat it every 30 days. If there's any concern about active diabetes, it's worth getting a hemoglobin A1C at baseline. And it's something you could consider, across the board. Similarly, you could consider a lipid panel and a CMP at baseline. And this is really more to, like, I don't know, maybe I'll say just show off that, hey, not only are we improving your body shape, but you did have a borderline elevated hemoglobin A1C. And even if it's just, you know, mildly elevated, 5.5 or something, if there's good data showing if you get it lower, that's better for somebody's health. Same thing with their lipid panel and the CMP. It's not like somebody just has, you know, high cholesterol, bad cholesterol, right? It all goes on a spectrum. So if you can get it from okay to good, that's actually pretty meaningful. You did something really important for that patient. And the same thing with the liver. If it's a little bit inflamed and now it's not, that's great. It's not that the drug is going to cause side effects with any of these things, so it's not mandatory by any stretch, but it might be helpful for just showing the impact that you're creating. Signs and symptoms of depression and behavioral changes and suicidality once on the prescription. So um, there, like, I think this is too early to really make any claims about it, but there are people who have said, they're having these major behavior or mood changes when they're on it, and something like, that kind of thing. I mean, food can be a real coping mechanism. So I think it's possible that that's a real issue. The other thing is there's some comments out there that, bars are not getting the food that they, or the clientele they used to get in some areas, because if you're on a semaglutide, you're probably not really excited to go do, like wing night or whatever, but maybe that's where you see your friends too. So it is something to at least talk about, I think, when someone's starting, and then, and then once they're on it. A lot of folks may also be on other, psych medications, so that's always going to influence things. You could repeat a fasting glucose. Again, that's more so if somebody is diabetic or pre-diabetic, or if they're having any signs, if they tell you, hey, I've been hypoglycemic before I do a big run and then I start, sweating and shaking afterward. I mean, that might be worth getting a fasting glucose just to make sure that you're not going to precipitate a problem. Um, and really, this drug should not cause hypoglycemia when used alone, but with other meds, it can increase the risk of hypoglycemia. Same thing with certain supplements too. I have some friends who, bless them, who are internists, in the hospital and whatnot, and they do see hypoglycemia with semaglutide, but it's really not the drug in isolation. It's something else is going on at the same time. All right. So side effects. Oops, sorry. There we go. Bruising, swelling, minor pain at the injection site, mild GI distress like indigestion, stomach fullness, and flatulence. The adverse events. So you want the patients to seek medical help if they have severe abdominal pain, persistent vomiting, other signs of cholestasis or pancreatitis, like severe stomach pain that won't go away. There are some, again, like I think it's social media where you can learn so much, right? But a couple of people who said, hey, I developed this severe gastroparesis that really didn't resolve for some time, even after coming off of semaglutide. So they were like really uncomfortable, for weeks. That's not something that happens overnight. So it's just something where you want, some monitoring and to make sure that they aren't running into unexpected issues. And if they are, then you can always titrate the drug down. Increase fiber, increase water, modify diet, etc. Allergic reactions always a possibility, and then dramatic mood changes. Okay, so I have said a lot. Hopefully, some of that was helpful at least. And I guess let's open it up for questions.
No, that was great, Patrick. Thank you so much. We do have a couple questions that have come in throughout the presentation, and just a reminder to everybody who is on the call, please, if you have any questions, submit them in the Q&A box. All right, Patrick, so a couple for you. Let's go ahead and start with just a question around pricing. I think it was a couple slides back where the recommended pricing was 300 to 500. And the question is that per month? Or
Yes,
okay.
per month. Yep. Yeah. And so some folks, and just to, right, this is kind of like people will go different ways where sometimes they bundle in a consult, sometimes they don't. And the cost of the drug uh, it is dose dependent. So if somebody's getting like they're on the lowest dose in the first, month or whatever, you could in theory charge less. Some people will usually people I think try to charge kind of similar, each month because it's just a simpler patient experience.
Okay, great. And then any recommended tips or tricks on how to bring up semaglutide to a patient who would be a great candidate for it in a gentle way?
Yeah, yeah, that's a great question. I actually, it's I started a couple of slides on that, and then I was like, that's going to take the whole presentation if I'm not careful, because I think um, it could be awkward, right? I mean, especially if they're coming in and they're looking for, their crow's feet to be worked on, and you're like, hey, have you thought about semaglutide? So I would just say I think it's always good to have like information, right? If you're the patient, you always want to be informed. You want to know what's out there, what options you have. And so I think it's worth just having something really small, like in a, brochure or listed on your Instagram, things like that. So just so that patients are aware of it, or maybe having have a small little sign in your space that says, hey, we're now offering this. Or if you want to, discuss it. It's a lot easier, I think, in patients who express any kind of, um, comments on their body where it's like my upper arms, or I have the cellulite, or like body contouring type patients. It's much easier. But I think coming at it from a place of empathy, because even if folks are not overly bothered by it, I think, right, it's interesting. There's been all this movement towards body positivity, which I think is wonderful, but the reality is there's still health side effects. So this isn't necessarily something where you're trying to sell someone something. I mean, this is really I view this as just an opportunity to really impact somebody's health in patients where we're more likely to encounter folks who are going to be interested in how they look, and we can direct this around their health. So I think soft stuff out there to help them bring up the conversation, and then just gently, if you notice anything, like if they've mentioned anything about their body at all, to have it out there. Also, intakes are incredibly wonderful, right? I've heard that from so many marketing and business people, that those patients who who you've seen for 3 years, who are just coming in for toxin every visit, it's great to do a what other interests are, say this is something I do every year, or we haven't done this, I do this every year, and we've fallen behind. I just want to know if there's anything else you're interested in, and they can just fill out a form. That's another opportunity.
Awesome. Okay, another question is, are there any known medication interactions or contraindications aside from DM meds?
Um, so basically, other ones that can cause constipation, I would say that's really your main your main group, and the same thing with ones that can cause heartburn. So that those are the main things I would say you want to think about. Some of the other drugs that are the other thing is, right, this can affect electrolytes if somebody is really not eating or drinking. So in somebody who's on like multiple blood pressure drugs and has impaired renal function, things like that, it's not really the drug so much that's a contraindication, but if it changes their eating dramatically, it's something you'd want to watch.
Mhm. Okay, great. And then any recommendations or tips and tricks from you on clients who maybe are a bit more aggressive and wanting to go on a higher dose to lose the weight faster?
um I mean, they can honestly, they can do it. I don't think it's unreasonable. I would just have that I'd have that documented really carefully, and really, if there's someone where I wouldn't do it with somebody who you don't know, but if there's someone, there are those patients who just follow things really well, and they are just highly motivated, and they do Sculptra, they massage 5 minutes and they've got a stopwatch, and those people I think are reasonable, where you can just tell them like, hey, we can go a little bit faster, but you are going to potentially run into some side effects. They're not dangerous side effects. So you really just have to keep up with the fluids, small meals, that kind of thing. I don't think there's anything wrong with that.
Okay, great. And then how would you compare the oral pills versus the actual injections?
Yeah. So, I mean, it's really just cost. They do cost more. And then the weight loss is not as dramatic. So I would say in general, semaglutide, somebody who's obese, you can say ballpark, let's call it 15% body weight reduction. The pills, 10%. So, works about as 2/3 as well. The one thing that will be interesting is if the shortage disappears, then the tablets may make sense in like a compounding sense, or I could see other avenues where semaglutide is compounded with other drugs, orally in the future. But for now, I think the injections for most people make more sense, unless they're like super needle phobic.
Mm-hmm. Okay, great. Let me pull up another question here. We have a lot of questions that are specific to existing portrait providers, just about where this information will live in our EHR. So will there be a specific section on the chart that will allow providers
Yeah,
to that information?
yeah. So that's a great point. So there's going to be. Yeah, so we're all about, good documentation. So there's one thing is there'll be a new like obesity overweight diagnosis, which anyone who's doing, we should always have a diagnosis for any treatment that we're rendering. So that would be something that whoever is doing a good faith exam, they would mark it, or for an advanced practitioner, ask you to mark it yourself. And then there's like, basically, if you look, you'll see the category of GLP-1, of semaglutide, and basically in there's a procedure note about like, what the patient was instructed on, and you just want to put in this is how much was administered and this is how much was dispensed to them. I think most people, again, will be probably doing these injections at home. There's one other thing I want to tell you about with it. Oh, so in California, we are actually using the real synthetic GLP-1 and not semaglutide. And the reason for that is regulatory reasons, that there are a lot of folks who they smuggle essentially semaglutide into California by shipping it to another state and then, sending it separately into California. It's frowned upon. The pharmacy board really doesn't like it. If something were to go wrong, I think it would be potentially a problem, and that's the feedback I've had. And you can actually get real GLP-1 produced. That's available. That can actually be sent in other states, but I think it is more expensive, and so some of that cost has to go to the patient, which is why we've kind of stuck with GLP-1 only in California, because semaglutide also more brand recognition.
Mhm. Okay, awesome. I think we have time for maybe one last question here, and then for all the ones that we haven't had a chance to get to, Patrick, I'll go ahead and make sure that these questions get to you, and we can address them offline with the
Yeah.
individuals who asked them. So, lots of questions just about clients asking about timing for a ballpark of how long they would need to be on this product. So is there a good answer to that? Just a ballpark of how long they would need to be on it? And then yeah, let's just start with that. Is there like
Yeah.
an answer for
I,
that?
I think I kind of think about this similar to how we would think again about just what's relatable to me is like is toxins or is maybe again like a biostimulant or something where it's okay if they come off of it. It's just the likelihood is that the effect is going to diminish and they're going to gain, at least some of the weight back. It's hard to keep it off. There are patients I've seen, I know who have been off of it for several months and seem to be doing just fine. It might be a little bit, we probably do get a little bit of a biased sample because I think most of the patients we're seeing are probably have a lower BMI than in some of these research studies. So maybe their set point is not as skewed. But most of them, I would say, you may just need to be on this, but you can always try coming off. So if you're worried about making them freak out that they're going to be like, addicted to it, so to speak, you don't have to tell them they're going to have to be on it. But I think most of them will probably stay on it or come off and then go back on.
Mhm. Okay, perfect. And I think we have time for one last question before we drop. Is there a time frame or a ballpark for how long a single vial should last a patient when they start?
Yeah, really depends on the vial size. So on the lowest end would be 1 month, which is typically what I recommend just from a cost perspective and to force the follow-up. After that, it depends on if they're staying on the low dose. Like you have some vials that could last them even like 6 months, depending on what dose they're on, and depending on what supplier you're using. So kind of hard to answer, but I would say generally the first one is only going to last them 1 month. The second one is probably going to last them about 2 months. And then you can probably put them on a 3-month cycle from there. And that coincides again really well with when you would normally want to see most folks back anyway.
Mhm. Okay, awesome. Well, I think just as a follow-up here, we've got a ton of questions just from our existing customer base about ordering turnaround times
Yeah.
and whether or not this could be
Like
used against beauty banks. So I think we should do a very comprehensive
more
follow-up.
details. Yeah.
Yeah, no, this is good that we're starting the conversation, but lots of follow-up questions. And so I think what Patrick, we can do is take some of these questions, translate them into, make sure we get them all addressed, and then we'll make sure to get that information out to um, our existing customer base to make sure that they have everything answered. And then for anybody else who had a question that we weren't able to answer this evening, we'll follow up with you one-on-one offline and make sure that we can get those addressed. So I
And
think we're
yeah,
right at the top of the hour, but Patrick, any closing thoughts before we wrap?
yeah, just thank you. Yeah, just a couple of things. One, thank everybody for your time. Um, in terms of folks who who are asking about orders, just we make sure that you've checked like the articles that we've published. We did place initial orders today, so we got like I probably think we set up like I don't know, 20 or 30 ship twos or something like that. And typically and this is just for anyone, basically, most of these compounding pharmacies, you're looking at a 6 month shelf life. I'm guessing that question may come up. And typically this needs to be coming either if it's not overnight, it's 2 night, it's like 48 hour because it needs to be shipped cold and stored cold. And so yeah, usually it's a pretty quick turnaround.
All right. Well, thank you so much to Patrick for that awesome presentation. And thank you to everybody for attending this evening. We will be sending this recording as a follow-up by end of day tomorrow. So thanks again and have a great rest of your evening. And hopefully we'll see you on our next webinar.
Okay. Thanks, everybody. Take
Everyone.
care.
All right. Bye.